We are here to talk about one of my favorite products that I recommend on a regular basis to many of my women who are trying to conceive, regardless if they have PCOS or not. It is called Ovasitol. It is made by a company, Theralogix, and I have the honor today of bringing on Dr. Ratner from Theralogix to discuss all the pros and cons, or I shouldn't even say cons, all the benefits of Ovasitol and who it's good for. And I know there was some really good questions on the post, and I'm going to address all of those, I promise. So I want to, let's see, I'll wait for Theralogix to request to join me live, and then we will get to it. But I myself have some questions and was also just reading some research on the effects of Ovasitol, inositol, the myo-inositol, D-chiro-inositol on the impacts of women with PCOS. There's a great review study that came out in, let's see, 2016 in the International Journal of Endocrinology. And what it showed after looking at literally over a dozen different studies of women with PCOS, 12 randomized controlled studies they looked at, they found, oh, here we go. Theralogix sent me a request to join live, but I just want to show you. In conclusion, the analysis of these clinical trials highlight the salutary effects of myo-inositol supplementation on improving several of the hormonal and reproductive disturbances of PCOS. Furthermore, the analysis lends prominence to the pivotal role of inositol, mainly myo and D-chiro, as a safe and effective therapy for PCOS, including enhanced oocyte follicular development, oocyte maturation, and stimulation in pregnancy outcomes. Amazing. So let's bring on Dr. Ratner. Let's do this. Some questions. Have a conversation. Let's see that it's working. I hit the accept. Okay. I'm hitting the accept. There we go. Oh, pretty view. Looks like you live near me. Where do you live?
Hey,
Hi.
for some reason,
Yeah.
it's using the back camera. Can you hear me?
I can hear you. Do you want to go to the other side, or it's not? It won't flip. It won't.
No, you know what I'll do? I'll just turn the phone around.
There. Oh, brilliant. That works. Nice view, though. Where are you?
I'm in Maryland. Can you see me?
Okay, I can. Hello, nice to meet you. Let's see. You froze for a sec. Huh. Okay, you're back. You froze for a second. Let us see. I don't know why you're freezing. All right. There you are.
Can you see me?
I can see you. You are here.
All right.
How are you today? Good?
I'm good. Thank you.
That's good. So tell us a little bit about yourself. You're at Theralogix. What's your role there?
Yeah, I'm a physician. I'm actually the founder and currently the chief science officer of Theralogix.
That's amazing. It's an amazing company. Congrats.
Yeah, we've been around for about 20 years now, and I no longer see patients in practice. I stopped about a couple of years ago, but before then, I primarily treated male fertility patients, and I worked with one of the largest fertility practices in the country. So I've got a fairly extensive knowledge of fertility, perhaps a little bit more on the male side than the female side from practical experience. But in my role at Theralogix, I've had a tremendous exposure to the published literature about inositols and PCOS. And we first launched our product like 5 or 6 years ago. And we struggled with what we like to call NIH syndrome, which means,
I
well,
was in research at one point. I know exactly the syndrome.
yes, it stands for not invented here. And you know, we had a lot of very blank looks from many of the doctors that we deal with when we would start sharing the published literature about inositols.
Right.
Because that literature, even 5-6 years ago, was already pretty substantial. And it's even grown bigger and better now. And so I think inositols have finally really become pretty widely understood in the States and much more widely accepted by clinicians.
Yes.
And I think the PCOS community has really been, in many ways, responsible for that.
Yeah, so I guess going to that point, do you think inositol is just for PCOS, like demographic, or do you think it extends? Because I know there's some research about egg quality improvement, right, in IVF.
It's a great question. There was a pretty big study that was published looking at inositol supplementation in women who were basically poor responders. In other words, they did not have PCOS, but they just had what appeared to be diminished ovarian reserve and poor response to a previous IVF cycle.
Right.
And women who were, this was a placebo-controlled study, and women who were treated with inositol did significantly better.
And the same ratio, like the 2,000 milligrams, the 40-to-1 myo decairo, or
yeah. I mean, the interesting thing is that most of the studies, I would say probably about 90% of the published studies, have used a 4,000 milligram dose per day.
Yeah,
you know, 2,000 milligrams, or 2 grams of the powder twice per day.
Right.
And you know, much of the original research was done using pure myo-inositol.
Right.
But it's been now realized that, you know, the body's normal ratio between these two different forms of inositol, myo-inositol and decairo-inositol, the body's normal ratio is 40-to-1.
Right.
And it's been shown that if you supplement with a 40-to-1 ratio of those two, it does a better job of restoring the body's normal ratio.
Right. And so how does the body's normal ratio get, you know, compromised, if you will?
Well, this starts to get complicated. Okay. And if I get too far out in the deep end of the pool, you know, drag me back. Yeah. So it turns out that myo-inositol is the form that is in 99% of the inositols in our tissues are in the form of myo.
Okay.
And both myo-inositol and decairo-inositol are second messengers for the insulin receptor.
Right.
They actually, when insulin binds to the receptor on the surface of a cell, in order for it to have its effect,
get brought in and be utilized, you need the
for sugar to come into the cell, for the cell to be able to burn the sugar for energy, or perhaps store it as glycogen for later use. In order for that to happen, the insulin receptor has to release second messengers into the cell.
Okay.
And the second messengers then sort of give the cell instructions, so to speak. And it turns out that the two different inositols comprise the bulk of those second messengers. And the ratio between myo and decairo varies from one tissue to the next. Now, because most of the inositol is in the myo form, what happens is there's actually an enzyme. It's called an epimerase enzyme, which we have in our tissues, it's in our cells, and its job is to convert myo-inositol into decairo-inositol.
Gotcha. Okay.
And what happens when somebody has insulin resistance,
they don't have that enzyme
in PCOS, is in their peripheral tissues, which means fat, muscle, the liver, actually. The epimerase enzyme is deficient. It doesn't
Yeah.
work properly. And so they are deficient in the conversion. They don't convert myo into dechiro enough in the peripheral tissues. But
It's
then
almost like MTHFR, where you're missing that ability to take folic acid into methylfolate, right?
Why that epimerase enzyme malfunctions in PCOS is still not really understood.
Right.
But the paradox, the thing that makes it so unusual, is that in the ovary,
right,
the epimerase, even in women with PCOS, in the ovary, the epimerase enzyme works fine. And so what happens in the ovary is actually you get too much production, too much conversion of myo.
And that's why. Got you.
So in the peripheral tissues, you don't have enough dechiro, and you have arguably too much myo. And in the ovary, you've got too much conversion, so you've got less myo and too much dechiro. So they call that the Ovarian Paradox, which is why too much dechiro, one of the original studies that was done with inositols in women with PCOS used pure dechiro inositol as the intervention. And what they found was as they increased the dose, the daily dose of dechiro, ovarian function got worse and worse and worse. And the reason was because the ovary is really deficient in myo.
Gotcha. So you need both,
But the peripheral tissues need a little bit of dechiro to reduce the insulin resistance in those tissues.
And so this delivery, like in your powder form of that ratio, helps with both, basically.
Exactly. That's the rationale. That's the rationale for it. And there are studies which show that the correction of the metabolic abnormalities, reduction in insulin levels, lowering testosterone levels, those metabolic abnormalities do better with the combined supplementation than with myo alone.
So that's important for everybody to know that, like, even if they're not going to get your product, which I think your product is the best one out there and has the most research, but that you can't just use the myo. You need the myo and the dechiro in that exact ratio of the 40-to-1.
Absolutely.
And then, so how does it help women that don't have PCOS? Is it that there is some level of insulin resistance that's starting, or blood sugar abnormalities that are impacting hormones, and there's something like that going on, or?
So it turns out that the inositols function as second messengers for other hormone receptors besides the insulin receptor. Okay. And the two others that we know that the best evidence exists for are the thyroid. Okay. So the thyroid stimulating hormone, that is essentially using myo-inositol also as its second messenger. But the other one is FSH, follicle stimulating hormone. And so the theory behind why it improves egg quality is that it's improving the ability of FSH to stimulate follicle growth. And so
and then there's some concern in the community. I hear this a lot with my clients of like, but I heard that myo-inositol diminishes AMH in women with high AMH that have PCOS. Will it diminish my low AMH? I don't, like, I usually talk them off that ledge in a sense of like, it's more about improving ovarian function and the output of the eggs from the ovaries. But I don't know if you can explain that at all, or if you see evidence-wise on that.
I think I'm going to have to plead. Keep in mind, my board certification is in urology, and so I treat male fertility. And so when I start trying to answer questions about female reproductive endocrinology, that's when I'm out in the deep end of the pool. And so I honestly, I don't really have a great answer for you on that.
So, but I still think, though, in general, what we're seeing is, and it makes sense, like whether they have insulin resistant PCOS or non-insulin resistant, or they're just dealing with fertility challenges, knowing that the myo-inositol secondarily impacts thyroid function and FSH, then I think that's where we're finding the improvement in egg quality, right?
Absolutely. Yeah.
And I also think, to the AMH question, I mean, the way it works in my brain, which, I'm not as deep in the research as you are, is just that those numbers don't matter so much, right? They change month to month, things of that nature. They don't necessarily represent, we don't know for a fact, but as far as we can tell, they have nothing to do with quality. And so what we're really trying to do is improve the quality of the functioning of the cells, and the myo and the d-chiro, that ratio helps to improve that. So I would almost just look at it as like, not so worrisome what it does to your numbers, your AMH or FSH, but more that we're focused on quality, right? That's what we care about. We want a quality embryo.
Absolutely. Yeah. And again, as I mentioned earlier, there are studies which show that for women who are poor responders, many of whom presumably, are going to either have low antral follicle counts, or
low AMH, I'm sure, and high FSH, right?
They do better with inositol supplementation.
And at that same dose, at the 2,000 twice a day, at that same dose?
Oh yeah. I mean, put it this way: that dose we know that dose is totally safe.
Yeah.
And there are actually studies out there that have looked at inositols for things like depression,
right,
which have used doses up to like 16 grams per day. And so, the dose is safe, and 4 grams per day is generally very well tolerated.
Right.
2 grams in the morning, 2 grams in the evening, with just dissolved in water. There is going to be maybe a small percentage of people who get a little bit of GI upset. They can get some like some loose stools from that, almost like a lactose type of intolerance, but not that common. And the powder is tasteless and odorless, and so it's pretty well tolerable. Interestingly, when we launched Ovasitol, our product, which is now almost 6 years ago, we were the only 40-to-1 product.
Wow, I remember that. I feel like I remember that.
And now if you go to Amazon, there's lots of them.
So what separates you guys? I mean, besides the research and the clinical trials,
So there's a couple of things. Well, look, the point here is that using inositols, and if you have PCOS, and you want to see whether you can get some benefit from inositol supplementation, the absolute minimum amount of time you'll need to take it is about 3 months.
Right. Okay.
And for most of the metabolic studies, looking at things like testosterone and skin and hair issues, you really need about 6 months of supplementation to see significant benefit for those endpoints. And so, we sell Ovasitol in a 3-month supply.
Right.
And the rationale for that is, that's really don't bother taking it for a shorter period of time than that, because you're not going to see the benefit you're hoping for.
Right.
And the other thing is we sell it as a full 4 grams per day. And so there's a lot of other products that are out there. And, I think I forget what our product costs. It might cost $70 or something in that range from 90 supply. But there are a lot of products there that, if you go to Amazon, it'll say 40-to-1, $19.95. Okay. And when you look hard, it turns out they'll say 30-day supply. But it turns out they're only giving you 2 grams or 2,000.
2,000. That's right. 2,000. It's not 4,000. Right.
And don't bother just buying 30 days. I mean, if you want to try and see if this is going to help, you need to do at least 90.
And I like how yours comes. I love the packets or the jar with the scooper. I think it's very easy. Yeah.
If you do an apples to apples comparison, we're clearly the least expensive product out there, but we're also the only one that's independently content certified.
Yeah.
And that's an important distinction, especially for women who are in sort of a reproductive time frame. You want to know exactly what you're putting into your body.
Yes.
And in the supplement world, that's not, unfortunately, it's not always a given. And And so our products go through a certification process through an independent nonprofit agency called NSF. NSF used to be part of the University of Michigan. It's now a freestanding nonprofit up in Ann Arbor.
Right.
And so that certification basically assures our customers what you're getting is exactly what you think you're getting.
Yeah.
And there's no contaminants or adulterants, and it's sort of content certified. So that's
Which
an
is super important. Yeah, that's one thing I always stress with. So many supplements out there have unnecessary fillers or binders, things of that nature that are no good for us or our fertility. And so I have another question. Metformin in conjunction with, because a lot of PCOS girls are put on metformin. I've also seen, I believe there's some, smaller research studies showing Ovasitol can have similar effects to metformin. Do you have thoughts or comments on that?
Sure. I mean, I want to be careful because we're not supposed to equate.
No, we can't. You're right.
A supplement with a prescription medication. And certainly anybody who is taking metformin now and doing well on it, I would never encourage them to stop taking metformin.
Yeah, always at the advice of your physician, guys.
Absolutely.
Always. Yeah.
Absolutely. Yeah. But I will tell you that in head-to-head studies, and there's several of them that have now been published, in head-to-head studies, not only looking at metabolic endpoints, things like insulin sensitivity or insulin levels, 24-hour area under the curve, results on insulin. Metformin and inositol supplementation are essentially equivalent if you use the proper dose. The only real significant difference between the two in most of the studies is that metformin has 4 to 5 times the risk of discontinuation because of side effects. So inositols are generally very well tolerated. They're safe. There's actually even a couple of studies showing that if you combine the two, metformin and inositol, it's actually better than metformin alone.
See, that's good to know, because sometimes I was hesitant of my girls that are on metformin. Is it overkill to also put them on the inositol? So that's very good to know.
Yeah. One other thing I'll mention, and that is, women with PCOS, when they do get pregnant, they have a 300% increased risk of gestational diabetes. And there are now about a half dozen studies that have shown that inositol supplementation for women with PCOS, if you continue it during pregnancy, it cuts your risk of gestational diabetes in half.
Amazing.
So it's certainly not only safe to continue during pregnancy, but
highly beneficial.
advisable. Yeah.
Yeah. I mean, because also gestational diabetes does a number on their body, but that also can really impact the child too, right? So it's like we want to, wow, that's amazing information. Okay, and so we have it listed on my site, I believe, too, the way I'm set up with you guys will get a discount if you order it through my site. I don't know if I have a link. I don't know, Beth, if you have the link, you can post it, or you guys can DM us. And so then I think the other thing, too, to really point out is it's not just for PCOS. Most of the studies are around PCOS, but then there is good information out there showing it helps improve egg quality as well, even in women who are poor responders. So to me, it's kind of like a no-brainer across the board that it's something that should be a part of everybody's fertility regimen. Yeah.
There's for women who are going through IVF.
Yeah.
And look, I worked with one of the largest IVF practices in the country for many years. So I kind of know how the IVF docs think, okay? And they love their technology.
Yeah, I know. They love it. And they love their success too.
Exactly. No, you're exactly right. They love their technology because they know how successful it can be, okay? But it's been very clearly shown that women with PCOS, when they go through IVF, they have a much higher risk of something called ovarian hyperstimulation.
Yeah.
Okay. And there was a study published in the past 12 months showing that if you're doing IVF and you have PCOS, staying on inositols dramatically reduces your risk of OHSS, of hyperstimulation syndrome, which is one of
Wow.
the more serious potential risks of
Oh
IVF.
yeah. I've had women lose ovaries from that. You know,
Yeah.
I've seen, I mean, just it's super uncomfortable. Hospitalizations, you know, to get fluid drained. Like it's a significant, can be a significant issue. So much
Yep.
so that always my PCOS girls, I kind of prep them leading into a transfer. Like, this is what you're going to do exactly after. This is how you prevent OHSS.
Yeah.
Yeah.
And the REIs have a tendency to sort of, well, and like we said, I mean, it's because it works
Yeah.
in most instances in a very predictable way. They kind of feel like IVF is the answer and the cure-all for anything that's going on, including PCOS. We'll get you pregnant, don't worry.
Yeah.
But the point is that some of these adjunctive steps, things like certain supplements, like inositols, like coenzyme Q10s, you know.
Yeah, you guys have a great CoQ10. I recommend that one all the time, the Neo Q10.
Yeah, I mean, not necessarily for PCOS patients, but for women who have egg quality issues, CoQ10 is certainly a good supplement to add in. But there's still a tendency that, you know, we know reproductive endocrinologists, the IVF docs from all over the country, and more of them are acknowledging the benefits of using these supplements in a complementary way. It's not all or nothing. It's not like either you just take a very natural approach with supplements or you do an IVF.
Do both.
Yeah, exactly. They're now seeing the benefits of doing both.
Yeah, I see it too. I've been in the field now for almost 20 years, and it's in the beginning, you know, the stuff I would recommend was poo-pooed or kind of ignored. I remember one doctor saying to a patient, like, diet and supplements have nothing to do with fertility, you know, at a very well-established clinic in New York City. I will not name names, but, and now it's, most of them have nutritionists on staff. They have supplements. A lot of them love your products, though. Theralogix is a very common one I see recommended.
5-6 years ago, we would talk to a lot of fertility practices about vitamin D supplementation, and you know, all of our prenatals contain a ton of vitamin D, like you know, 2,000 to 3,000 units per day, and
choline. You have some good choline in your prenatal too, which I appreciate greatly.
5-6 years ago, we got so many shrugs, shoulders, and blank looks about vitamin D, and now I would say in virtually every fertility practice in the country, it's part of the screening blood work.
It is.
So,
it is.
You know, they want to make sure that if you're going to go through an IVF or an IUI cycle, your 25-OHD is above 30. They want to get to
and they see too, it improves AMH. Your D's higher, your AMH is better, which is interesting. You know, there's like a direct correlation, and that's because vitamin D is not a vitamin, right? It's a hormone, and it's a pro-steroid hormone. It helps all your other hormones in your body, guys. Yeah.
You must. That's exactly. It's funny. That's a line I've been using for like 10 years. Yeah, really? Vitamin D. What's the definition of a vitamin? The definition of a vitamin is a compound that we have to get from our food that's essential for our metabolism, okay? And what's the definition of a hormone? A hormone is a substance that's made in one part of the body and functions in others.
Another part,
Yeah, and so vitamin D fits the definition of a hormone. It's not a vitamin. There's almost no good food sources for vitamin D. People think, oh,
none. Yeah.
Right? No, you get vitamin D in milk because the milk manufacturers have to put it in there. They have to add it.
And it's typically soy-based and crappy vitamin D anyway, or it's in like a soy oil.
And so, you know, the point is that vitamin D, you're absolutely right. It's a hormone. It's not a vitamin.
This has been great. So someone else just asked a question, though. If they're on metformin, do they still take the regular dose, the 4,000 or the 4 grams? Do you recommend still the same dose?
I think so. I don't think that I'm not aware of any reports of people becoming hypoglycemic.
Yeah, that's what I was going to say. I mean, if you're on metformin and you have PCOS, that's insulin resistance, you know, it's probably smart to be checking your sugars. You know, you could even do one of those glucose monitors and you could go and see, but I've never seen that either. I've only seen kind of what you're saying.
I mean, there are no reports of excess insulin sensitivity in the literature. So I think it's safe.
And if anything too, it's like insulin's just, it's so critical to all of us, whether they have PCOS or not. And, you know, so much of what I do, even diet and lifestyle, is just balancing blood sugar because it balances hormones. And we see that, we know it, we feel it, we see it in our cycles changing. So adding something like Ovasitol to your fertility regimen, to me is a super smart thing to do. And then I did just get, you guys get $10 off if you order it through me. It's aimeeraupp.com/Ovasitol, OVASITOL. And yeah, maybe we have you back on and we'll talk about some of your other products, because I like your prenatal is great, your Conception XR, your Neo Q10, right? That's what it's called, Neo Q10, isn't that what it's called?
Yeah, Neo Q10 it's a coenzyme Q10 product. And what makes it sort of unique is solubilization.
Yes.
CoQ10 is extremely difficult to absorb from your stomach. So one of the things that people always say, what's the best dose? How much CoQ10 should I be taking if I'm 38 and I'm trying to conceive? And the answer is that it's not what you ingest, it's what you absorb. And so the form that the CoQ10 is delivered in is really important. And Neo Q10 is basically the CoQ10 formulated with an emulsification agent that about quadruples the absorption compared to standard.
So you need less, right? So what, you need like 200, or what do you recommend?
Yeah. So a lot of women may have heard this 600 milligram number, and the 600 milligram number on CoQ10 comes from one of the first studies that was ever done by a doctor, Bob Casper, up in Toronto, who dosed women with 600 milligrams of an oil-based coenzyme Q10. Oil-based products typically have in the 2 to 4% range. And so the point is, our product, which has anywhere from 3 to 6 times the absorption of that type of oil-based product, we suggest about 250 milligrams a day.
Yeah. That's what I like about yours, is you can get more bang for your buck, basically. Yeah, you're getting less. And I've also seen too high doses of CoQ10 make women really jittery and anxious. I don't know if you've heard anything about that, but I don't know, it's very stimming, it seems like. So okay, this is great. So any last things you want to say to this audience?
No, thank you. It's been great talking to you. If we talk again next time, I'll make sure that my forward-facing.
You were great. It's Instagram, super casual.
I've been looking at the back of my phone for the 30 minutes.
You can't even see your face. I know. That's okay. You did great. It's awesome. And so yeah, guys, aimeeraupp.com/Ovasitol, OVASITOL, and you get $10 off. And like Dr. Ratner said, 3 months minimum, I think, to really see the impacts on things, and that you are taking the full dose of the 2,000 milligrams twice a day.
Right.
Yeah. All right. Thank you. And you guys check out Theralogix. They have great products across the board and super backed by science, which obviously is very respectable and trustworthy. So thank you.
Thanks again. Bye-bye.
Okay. Goodbye.